Good evening, everybody. My name is Bruce Holmblad. I'm the president of the Riverside County Medical Association. I want to welcome you to our bi-weekly conference call with Dr. Cameron Kaiser, our public health officer. I can't say enough just how much Dr. Kaiser has done for our community. I know that I feel much safer. I know my family feels much safer. He's made multiple decisions, has been way out in front on the masking. And without any further ado, I'd like Dr. Kaiser to just kind of give an overview, and then we can ask the questions that have been submitted by our docs. So Dr. Kaiser, you have the floor.
Thanks as always for the kind word, Dr. Holmblad. First of all, I'll make my usual introductory remarks and then do a brief update on the COVID-19 response. Today, we are reporting a cumulative total for Riverside County of 56,374 cases and 1,143 deaths, with 51,651 total recoveries, recording 173 new cases and 7 deaths today, though always keep in mind that these numbers are cumulative over a window period and not necessarily 24 hours. However, these numbers still indicate the virus is still very much in circulation and really hasn't shown any decline in the infection fatality rate, but the attack rate is clearly down from the deadlier months of July and August. This has led to much speculation, and I see that we have questions on it, on whether Riverside County will be able to advance through Governor Newsom's new color tier strategy. And after this call, in fact, I'm on a CSAC call where that topic I'm sure will be discussed in great detail. But I won't feel comfortable saying that we have dodged the Labor Day bullet, and probably until we get in everything over this weekend. If we remain at levels sufficient to advance in terms of our daily average case rate, then this would move us into the red tier, which is the second most restrictive tier, on or around the 22nd. In Governor Newsom's framework, this would allow retail occupancy capacity to move to 50% indoors. That includes malls. The remainder of personal care services to return to full indoor operations. That includes things such as nail salons, tattoo parlors, and such. Museums, zoos, and aquaria to 25% occupancy indoors. Places of worship to 25% indoors or 100 indoors, whichever is less. Movie theaters to 25% indoors. Gyms and fitness centers to 10% indoors, including hotel fitness centers. And restaurants to 25% indoors or 100 indoors, also whichever is less. Wineries, card rooms, satellite wagering, and family entertainment centers must still remain on outdoor operations. Bars remain closed, and offices should stay remote. Professional sports may not have a live audience at any point until the state is considered fully reopened, which is not addressed by the colored tier strategy. Much speculation has been made about amusement parks, but no guidance has dropped. And the state is still internally debating over private gatherings, which I do note remain prohibited for the record and are probably our largest source of spread based on contact tracing data, as well as Halloween, of course. We would also have to be in the red tier for at least 2 weeks continuously before schools could reopen. Once that occurs, the current TK through 6 school waivers program would end, as schools would not need to seek my public health officer approval to return to in-person or hybrid instruction, but they would still be bound by all applicable state guidance enforceable by CDPH and the California Department of Education. Although it is possible for a county to regress to a more restrictive tier, and this may yet happen actually in San Diego County due to their current large outbreak at SDSU, schools that are already open would not need to close if that were to occur. You will have also heard, and I know we have a question on this later, that Riverside County, and for that matter San Bernardino, and this is hardly a problem unique to us, has had its case rate penalized due to low testing volumes. This is based on published research on how many cases are likely to be detected per unit testing. So we are charged with that expected excess if we don't test enough to prevent jurisdictions from simply gaming the system by just not testing anybody. We are still able to advance even with that penalty, but we are trying to boost our testing as much as possible, not only because the Board of Supervisors is advocating for a reopening position and this would retard our progress, but because we really need as good a surveillance of the population as possible due to concern with asymptomatic spread in those less vulnerable individuals. The chief problem we're having is that nobody's interested. We have unused capacity at our testing sites, and we are trying to redirect it to test groups that need regular surveillance testing. We have had issues with access on some of them, and we're trying to shore them up, such as schools. We think that the lack of interest is due not only to the usual things such as testing fatigue, sensational stories of swabs going up people's noses, and the usual Facebook disinformation, but also parents concerned their kids could be blamed for a school shutdown, which is not an unreasonable concern. People unwilling to isolate, and individuals unwilling to work with contact tracers if they were to test positive. That brings us to antigen testing. Antigen testing is probably the most accessible testing needs for ambulatory settings, and there are now at least a couple of point of care CLIA waived assays which are available. The one that's probably gotten the most press recently is Abbott Binax Now. This is a card-based test which HHS is reportedly shipping to SNFs and long-term care facilities directly. Unfortunately, antigen testing presents two major problems, namely some variability in the sensitivity and specificity between those specific assays, and that initial problem with insufficient sensitivity, which is still an issue for asymptomatic individuals, but also statistical reporting. We are absolutely certain that most point of care tests, particularly negatives, are not being reported to us. And this is required by CCR 2500 that we get everything. The mid-size and the large labs running PCR and volume are all on electronic laboratory reporting, and we get those data dumps regularly. But most antigen tests are reported piecemeal, which means for delays entering the data, data that may never be received in the first place, and then the state does not currently count antigen tests as tests for the purpose of tier advancement, which is why we currently report them as probables, and we had 25 in that category today. To that end, our executive office has written a letter to the interim CDPH administration and to HHS Secretary Mark Ghali to request that this be rectified. In the meantime, we report these tests as probable positives pending confirmation as clinically indicated. If you are doing antigen tests in your own offices, please, please, please take note of all negatives as well as positives in your logbook and send us everything. If you don't know how to do this, please contact me separately after this meeting. I will be happy to hook you up with our EPI group. Even if they're in some sort of electronic format, that would be great. We'll take an Excel spreadsheet. That suffices. But even if it's going to be pages in a binder that you fax into us and we type in, that's still better than nothing. And you will be doing your part to ensure we have good surveillance as we enter what may be a very strange combined flu and COVID-19 season in the next few months. But we're going to talk about that during some of the questions. So Dr. Holmblatt, I'll hand it over to you for those.
Okay, thank you for your insight here and your report. So we'll go ahead with question number one. What is the state or Riverside County's planning for prioritized distribution of SARS-CoV-19 vaccines? When do you anticipate there will be a viable vaccine that we should promote?
With respect to the vaccine, we are likely to fall under whatever state framework eventually exists because the federal allocation of California to California will almost certainly be gated through CDPH, and they will probably dictate that strategy to the locals as a condition of receiving an allotment. Currently, the National Academies of Sciences, Engineering, and Medicine suggest that health providers, first responders, older adults in long-term care, and those with chronic conditions such as diabetes should be the ones first in line. There is also some discussion at the state level of what that might mean for disadvantaged communities who have been disproportionately affected by COVID-19. And you can see that locally in some of our ag communities such as Mecca and North Shore, which have really gotten pounded by it. Coachella as well, Indio, that area. There's also logistical issues of transport and if a booster might happen to be required. And then, of course, the possibility the vaccine strategy might involve multiple potential vaccine candidates being used as availability warrants, which may mean we are tracking multiple supply chains. Though we as a county, we're actually, and I say this with all justification, we're actually pretty unusually well prepared for this because we have an airfield right next door to our warehouse, and our warehouse is used as the state staging area. And that means that what comes down here gets run through us, which is quite useful in certain circumstances. We would likely use a distribution means similar to what we did for H1N1 in 2009 and utilize the existing points of dispensing that we established then. That said, I still don't realistically see a vaccine entering mass production much before the end of the year. and little information has emerged on the phase 3 trials, which personally I find rather troubling. Many of you have heard the AstraZeneca Oxford vaccine candidate trial was temporarily halted due to an unspecified neurologic complication. But we really don't know what it is. Was it Guillain-Barré? Was it something else? Nobody has really said, and it's not at all clear whether it's attributable to the vaccine itself. If the data is good, I will say here and now that I will be first in line, and I know that our public affairs office will have the pictures to prove it. But while I think a lot of hard work is occurring at the federal level, and I don't want to short shift it, it takes time for good data and solid production. And I think we should be prepared for the possibility that we may not be looking at wide distribution until 2021.
Okay. Well, thank you. Question number 2, until such time there is a viable vaccine, what should be our message to our patients?
I think the message should be the same message that we are giving now. Facial covering, social distancing, and avoiding gatherings, even if you know them and even if they look healthy. I think when a vaccine does emerge, I think people more than ever will look to us in the physician community to bless it, for lack of a better expression, by whether we choose to get immunized ourselves. And there is certainly talk about whether harm reduction messaging should be playing more of a role, since we are seeing greater discontent, let's say, with closures and restrictions becoming more prevalent in some communities. Now, I don't, the analogy with STDs and abstinence has been brought up. I'm not sure if that necessarily holds, since I'm not aware of any airborne STDs. But nevertheless, I do think the core messaging of what we can all do on an individual basis, at least, is indisputably supported by the present science. And I think keeping those messages as clear and simple is the best thing that we can do as providers until we see the end in sight.
Okay. Question number 3, can you please comment if schools are being granted school waivers?
The answer is yes. 26 schools currently are cleared to operate, and I have about 4 more applications to review, which I will do after my CSAC call, because there is no shortage of work these days. The schools have all gone through a clearance process with our schools and education special unit, and we have a standard application that requires them to present a reopening plan and an application, which needs to have social distancing, classroom design elements, requirement for facial coverings for staff and students, staff surveillance testing, and then case response capability. Each one of these schools is personally signed off on by both me, by state requirement, and by a school's contact at CDPH. Schools may only operate the transitional kindergarten through grade 6 grade span due to a belief based on some earlier ecologic studies, particularly the South Korean one many of you have heard about, that at least showed the suggestion children under 10 are not major drivers of disease transmission in household settings where you would expect the highest risk. Based on that grade span is believed to be lower risk and the ones who would benefit least from distance education, whereas grade 7 and up remain on distance education for the duration. I'll note we have not had an outbreak in any of these schools to date, but most of them have only been open a week or 2, so it's probably too early to say anything about that. I have had some initial complaints of teachers not wearing masks and social distancing procedures not being consistently observed. But in fairness to the schools involved, when you're given pictures by concerned parents, there's not a whole lot you can say. And they did submit to me corrective action plans, and to date, no further complaints have been received. As I mentioned previously, should Riverside County move to the red tier and remain there for 2 weeks continuously, then schools may reopen all grade levels as they determine appropriate without health officer approval, and the waivers program will end. I think I can say, with, again, no hyperbole, I have really gone to great pains to ensure these schools have good plans in place because it's my name on the letter. Unfortunately, this may mean that the process right now may not be very predictive of what happens when schools reopen generally, because I'm not going to have that level of oversight over the process. They can open with me or without me. And all 26 schools presently open are private institutions. Even though public schools are welcome to apply, and I think I do have one in my hopper, the ones so far are all private. They naturally serve different demographics. Families are less likely to be essential workers. They are more likely to avail themselves of means of avoiding exposure. They're more likely to be in areas of the county where disease spread is less. We do offer technical assistance to school districts, and some have availed themselves of that, but they are not under any obligation to do so. So if you have any concerns about your local district and what reopening plans they may have in mind, that may be something you would want to raise with them directly.
Okay. I think you've actually answered a little bit of question number 4 here, but I'll read it completely. And Riverside County just moved to the red tier effective September 22nd, 2020. Please explain what this means for Riverside County. It appears all schools can reopen. Also, all businesses are reopening. What are your thoughts on the mass reopening?
Well, as previously mentioned, Riverside County has not yet moved to the red tier, at least not of this date today. We have to remain in the purple tier for a minimum of 3 weeks, during which we must meet the red tier criteria for at least 2. We have done so for 1 week, so if we continue to do so by next week, then on the 22nd, as stated, then we can move to the red tier. As I said in my initial remarks, the governor has made public statements that he believed the earlier attestation process, which technically is still in effect, but it moved counties to reopen too quickly and resulted in the July-August surge. So even the motion to red tier, as I mentioned, this is at best only partial. And even at the lowest yellow minimal tier, not all previous activities, particularly with respect to large gatherings, will be permitted. As I mentioned in the last question, schools can only reopen after you remain in that red tier for 2 weeks. So that is at least 3 weeks away before they could do so, even under the best circumstance. And even those business sectors that can operate, and that's not all of them, they will only be permitted by the state to incrementally add indoors capacity at the red tier, and thus at this level.
Okay. Question number 5, and before we go, just there's a note from the RCMA to download the revised healthcare workers guidelines. Please go to www.rcma.docs.org portal 17 asset docs COVID. Boy, that's a mouthful, but please read that. And here's the question. If an employee who has interaction with patients tests positive for COVID-19 after becoming symptomatic, A, do we need to notify all patients and caregivers the employee was in contact with? If yes, how many days before symptoms? B, if other employees are asymptomatic, do we still need to test? And C, do we need to quarantine the entire office for 2 weeks?
You are certainly permitted to notify patients and caregivers, or we can assist you with that process if you have concerns of doing so, since obviously we're very used to doing that. The employee would be considered communicable 48 hours before the onset of symptoms or the date of their first positive test, whichever is first. Testing asymptomatic employees is never discouraged. We always recommend that in an exposure situation, regardless of the CDC recommendations. It should not be done before day 5 after exposure, however, so that your sensitivity is maximized. Optimally day 7, but no earlier than day 5. Now, if they become symptomatic, of course, then you should test them immediately. As far as the office itself goes, the governor's executive order permits healthcare workers to continue working with a surgical mask during their 14-day quarantine period. This is permitted, but it is not mandatory. And as I mentioned on our Monday call, they still remain on quarantine in every other respect when they are not on the clock. If you are concerned that having them at work could be a risk for your practice, and you may make that consideration based on your normal patient mix and who's likely to come in through your door. A rheumatologist with half of their patients on Remicade, that could be a concern. Or you have too many symptomatic people who are out of work, then you always have the option to close, even though we don't mandate it. It's probably going to end up being a decision based on how many people in your office end up being affected and whatever you judge as the minimum complement of workers you would need to effectively operate.
Okay. Question number 6. I understand testing has slowed down. What can we do as physicians to promote patients to get tested? Are there guidelines or restrictions for people who want to be retested again and again?
The problem with testing is that certain elements have spread the word of various, let's say, falsities. and some other concerns which may resonate with particular individuals. And one of the falsities which I've heard is that the PCR test has false positives, but anybody who knows anything about molecular testing knows the major problem is they too often test falsely negative. And because they are molecular and they look for specific, in this case, nucleic acid sequences, they are highly specific. People are going to shed virus for a while, which may not be clinically relevant, but that's a problem specific to individuals who have tested positive before, and I'll talk about that in a moment. But what also seems to be resonating with people is what happens if they test positive. And I think it's interesting that many people think they might, and so are not testing, which makes you wonder about how well people in general are adhering to public health recommendations generally. I'll just leave that there. That said, even in the best case where they are likely to do well, and this is of course the majority, if they test positive, they would still need to be excluded from work and they would need to self-isolate. And since this would be inconvenient, especially if they are not themselves ill, then I figure that's why they don't bother. I think we need to reiterate to people, especially those who have medically vulnerable family members or who work with people who are, this is to break the cycle of transmission and to prevent further disease so we can, if nothing else, consider the self-interest of trying to get things more open as we progress through the new tier strategy. I mean, to the reopen now crowd and the COVID-19 is a hoax crowd and the only 6% of COVID deaths are really COVID deaths crowd, I mean, that's not going to mean much. But I think to reasonable people who appreciate that there is a death toll and we don't want it to be larger, and we need to do what we can to get the numbers to stay down until a vaccine arrives, and I think this may have some staying power. With regard to testing, we have always advised strongly that once you test positive, you should not be retested, if for no other purpose than clearance purposes. I mean, other than our brief and sorrowful fling with test-based criteria back in those early days so long ago in March and April, we just don't do it anymore, really. And we don't advise those people be tested again, sometimes for up to 3 months. In addition, the state does not count retests on positive individuals either, presumably for that reason. However, there is no such restriction on negative tests, and particularly for people in lines of work where surveillance testing is required, such as people in SNFs, people in schools, we need to ramp that up because they should be getting retested and preferably on a regular rotating cycle. One interesting thing, some of you may be unaware that not all of the testing sites in Riverside County are operated by Riverside County. Some of them are operated by a state contractor called OptumServe, and some of them are actually operated by Google under their Project Baseline Verity project. And if Google can do anything, it's get data. And one interesting thing that we've gotten from the Verily data is how much the same population we are testing over and over. So our hypochondriacs have already figured out where they can go. It's now time to sort of broaden that to the population at large. And if your tests if patients have never been tested before, it may be worth offering them one. And if you can't do it yourself, then please send them to one of ours. The website is gettested.ruhealth.org. And I'll send that to Dolores so she can push that out if she likes.
Okay, I appreciate that.
In fact, I'll type in the chat box on here.
Okay, question number 7. What is the status of contact tracing in Riverside County? Is it successful?
I think it is successful in the sense that we can get some useful data. However, as I mentioned before, the presence of contact tracing has been cited by people as a reason not to test, although it is debatable if those folks would get tested anyway. And many people just plain don't return our calls. There is no state mandate or county ordinance, unfortunately, that requires that they comply, and we have to rely on their willingness to do so. That being said, we do have some patterns, and with the exception of those business sectors that have been closed for the duration, what we've seen, at least initially, is that private gatherings and household contacts are the biggest. You would expect that, really, because they have the most contact. They are usually not wearing masks in those situations because, hey, it's a gathering and you're among friends and they look healthy and they appear well, so why do I need a mask? And surprise, somebody was incubating and they're in their 48 hours. However, workers in certain situations, surprisingly offices, possibly this may reflect something about ventilation systems, warehouses, retail settings have also ranked quite high. This should be considered in the context, though, of what's open. Gyms don't rank very high, for example, but they're not open. Ditto for bars. And it is unlikely that somebody would rat out the underground gym or speakeasy that they've been using to drink or work out in, or possibly both. The state has made some notable improvements to the CalConnect's statewide contact tracing database system. We were originally looking at some other solutions, but we are impressed that they have really tried to work on some of the data reporting issues that it's had. Previously, they relied excessively on free text entry, which is really difficult to get any kind of signal out of, and they're moving now towards a more categorical approach, which is much more amenable to our automated systems to try and get large reports. If you try and do these kinds of things manually with thousands of contacts, you'll go crazy. And our EPI people probably are already halfway there already. But at least with this system, this gives us the potential for better impact and better reporting tools. So we hope to see higher quality data start to come out of it as a result. And as we move through the governor's color tier strategy, we may see some different signals start to rise, and it may be useful to do sort of a before and after. And that's going to be something we'll be talking about in detail with our EPI group to make sure that whatever we're representing, we've got a this is now, this is then kind of perspective, so we are not running over old ground when we try to make any different kinds of policy decisions in the future.
All right, I appreciate your time here. Do you have a few minutes to answer some of the questions in the chat box, or you need to get on to your next meeting?
I probably should soon, but I don't see any in there.
Oh.
I'm replying to one private query, but I don't see any others. They're just links.
Oh, okay. Okay. No, they're just links. Well, having said that, I want to thank you again for your time, your expertise. I did want to make an announcement. Our bi-weekly meeting will move to monthly, and the next monthly call will be the second Tuesday of October, which would be October 8th. Dolores will send more out. But once again, Dr. Kaiser, thank you for your time and your expertise. I speak for all of the RCMA. We really do appreciate everything that you have done for us.
We had one more question that came in.
Oh,
if we can do it real quick.
Okay, sure. It just came in?
It just came in. It says, how do we report antigen testing?
Yeah, I put my email in the chat box. Send me an email about that, because what I'm going to have you do is plug in with our reporting system, so I can, I can say something, but they have to live with it, and I want to make sure that the process is there. We favor electronic, please, if you can, but if it's going to be a matter of the only way you can do it is faxing it over to us, we'll take that too. Email me and we'll help you figure it out.